there's a common problem in the daily practice of our colleagues in which we receive a patient with a series of perimetric examinations made with different devices. For example, one with octopus, the two next with Humphrey, and then Deacon. And how do you advise to manage those patients in terms of comparing and having any idea of?
It's not an easy one. It's still a problem. As you know, the Moorfield's progressor and the peridata and the eye suite can analyze different machines, but not one with the other, unfortunately.
Yeah.
So when you have in front of you visual fields printouts of different machines, there is no other way but to look at the grayscale and at the indices. That's what I do. And what we do when we have patients that are referred to us, we know the machine that is used by the ophthalmologist, and we continue to use the same one. We have an octopus and an Humphrey, and we do preferentially octopus if the referring doctor has octopus, and vice versa. But it's not always possible, especially in patients that come for a second opinion. And then you are left with the grayscale and the indices. My name is Thierry Zeyen from Belgium, and I would like to give an update on visual field testing in daily practice. We'll talk first about why is it important to test the visual field, something about programs and strategies, artifacts, how to use the available software to interpret the visual field, and finally a word about non-conventional perimetry. Why is it important to test the visual field? Well, we know that functional defects can occur before structural defects are detectable. And we know that from the two most important studies about ocular hypertension, the European EGPS and the American OATS, that showed that in 60 and 40% of the patients, visual field loss was detected before any optic disc loss was visible. So both functional and structural tests are important. Second, visual field testing allows for staging and calculating rates of progression. We will talk about that later. And finally, visual field loss is associated with reduction in quality of life. As you can see in this graph, a group of patients with glaucoma and a mean MD of 4 decibel in the best eye had in 1 year twice as many falls than the control group in the same period of time with normal visual field.